Advanced manual therapy techniques for the elbow, wrist, and hand, functional testing of the flexor mechanism of the hand. Before applying any manipulative techniques, manual therapists must accurately assess the functional integrity of the finger flexor muscles. Two specific clinical tests are used to evaluate the superficial and deep flexor tendons of the fingers. Flexor digitorum superficialis, FDS test. The practitioner instructs the patient to flex the proximal interphalangeal joint of the target finger while keeping the other fingers extended. Positive sign: inability to flex the pip joint. Interpretation: indicates disruption or dysfunction of the FDS tendon. Flexor digitorum profundus, FDP test. The examiner requests the patient to flex the distal interphalangeal joint of the specific finger, again while keeping the other digits extended. Positive sign: inability to flex the dip joint. Interpretation: suggests compromised function or rupture of the FDP tendon. Allen's test for arterial patency. This test evaluates the patency of the radial and ulnar arteries supplying the hand. The patient is instructed to make a tight fist and open it repeatedly. With the blood pumped out of the hand, the examiner compresses both arteries and then releases one at a time. Positive sign: delay in the flushing of the hand upon release. Interpretation: suggests occlusion or compromised flow in the released artery. Manipulative techniques for the elbow region. Radial head manipulation. This technique targets restrictions or dysfunctions at the proximal radio-ulnar joint, particularly the radial hedge. Supine, seated, or side-lying. Practitioner position: standing beside the affected arm using an asymmetrical stance. Procedure: locate the radial head laterally with one hand. Grasp the wrist with the opposite hand and bring the forearm into 45 degrees of pronation. Apply a directional force to the radial head while simultaneously pronating the forearm, flexing the wrist, and fully extending the elbow. The thrust is applied obliquely along the plane of the radial head. Key points: flex the elbow to 90 degrees to better locate the radial head before manipulation. Stand close enough to prevent overextension during the thrust. Hyperextension must be avoided to protect the capsule and ligaments. # ulno-humeral joint manipulation, ulna-cranon contact, used to improve mobility and alignment at the ulna-humeral articulation. Patient position: supine, seated, or side-lying. Practitioner position: standing adjacent to the joint. Procedure: form a semi-clenched fist and use the thumb and second finger to cradle the medial and lateral epicondyles. Use the other hand to grasp the patient's wrist. As the practitioner extends the elbow, a superior directed thrust is applied through the humeral condyles. Key point: avoid excessive force and hyperextension, especially in patients with ligamentous laxity. Wrist and carpal bone manipulations. General carpal mobilization. Ideal for restoring motion in the small articulations of the carpus. Patient position: supine, seated, or side-lying. Practitioner position: facing the patient at table side. Procedure: the patient's hand is fully pronated and held with both practitioners' hands. Identify the target carpal bone and place both thumbs over it. A controlled flexion-extension movement is performed, applying the thrust towards the palmar surface during the extension phase. Key points: preload the joint by using combined levers, e.g. traction, radial ulnar deviation. Stretching the thenar and hypothenar areas increases effectiveness. Suitable for mobilizing most carpal bones. Thumb and first metacarpal joint techniques. First metacarpal manipulation, thumb base. Patient position: supine, seated, or recumbent. Practitioning on the same side of the affected thumb. Procedure: the practitioner grasps the patient's thumb with one hand. The thumb of the same hand palpates the groove between the proximal first metacarpal and the trapezium. Traction is applied to open the joint space, and the manipulating thumb is placed over the joint line. The opposite palm reinforces the thumb position and directs the manipulation. As the patient exhales, the thrust is applied downward along the plane of articulation. Key points: patient may be asked to slightly lean back to enhance traction. The manipulation should be smooth and free of excessive force. First, metacarpal manipulation. Secure the carpals using one hand while palpating the metacarpal trapezium junction. The opposite hand grasps the phalangeal joint of the thumb.